but hopefully there's a couple of pearls in there that add into what people already know. And if you're really starting out in skin cancer medicine, hopefully this might serve as a basis for doing a little bit more in your own practice as a GP in rural areas, or even working a bit more dedicated in skin cancer work. There's certainly it's a growing field, as we say. There's lots of sun exposed bodies around the state. So yes, hopefully you can get a bit out of tonight. Look, I'd just like to echo the acknowledgement to country. My ancestors are from Scotland and Ireland years ago and brought my pasty white skin to Australia. Certainly acknowledge the traditional custodians of this land, and I'm speaking from Nadgery country here, and I grew up in Wurundjeri country over to the east. So wherever you are, I hope you're connected with your land and your people around you. So a bit about my journey. So I'm a Flinders graduate more than 10 years ago now. It's about 15 years since I graduated as a doctor. I spent some time in Jamestown with a lovely fellow called Ben Abbott, who taught me a little bit about skin cancer medicine and some flaps. I had a really nasty case at the Reaper Hospital. It was a 44-year-old fella who had metastatic melanoma. And really that was what made me think, gosh, this is a terrible disease. And it wasn't until I was in Woodner on the West Coast in my first GP registrar placement that I thought I need to know a lot more about this skin cancer medicine stuff. I was seeing a lot of patients with skin cancer, and I really needed to force myself to learn a lot more about it. As you guys know, through med school and often through GP training, we don't actually get much in the way of skin cancer teaching. So I did my fellowship year after I fellowed as a GP on the Mid-Air Peninsula, working across Kimber, Cleve and Elliston. Again, really starting to hone my skills in general practice and skin cancer medicine. And since moving to Clare, which has been my base, raising a family, is where I've really started to hit my straps as doing a lot more work in the skin cancer space, working with the Cancer Council, working with international research projects, and having a family. And then, yeah, as Monica said, I've started up an outreach skin cancer service at a lot of places where the GPs were too busy either to do skin checks or didn't have the skills to perform flaps and grafts. So finding that niche between what GPs can do and a plastic surgeon or a visiting surgeon. So I'm enjoying that work. It's a nice break from general practice, as maybe a few of you guys are interested in this work for that reason. So there's a bit of heritage there. My great uncle on my mum's side, he was a anatomical pathologist in Brisbane, and he was actually involved with looking at melanoma back in the 70s as a pathologist. His name was Jack Little. And yeah, so he was doing work in melanoma, and I got into medical school well after he had passed away. So I sort of like to think that the family's happy that I'm carrying the flame forward. So why is skin cancer medicine important? Well, it affects a lot of the patients that we see every day. The stat that I like to have off the top of my head is that by age 70, 2 out of 3 Australians will be diagnosed with skin cancer. That's a function of pale skin in a outdoor lifestyle, quite a high sun exposed country, and a lot of rural work. So when we're working in rural areas, especially, we're seeing patients that are farmers, we're seeing patients that are teachers, vineyard workers, people that are outside a lot. So skin cancer is a very important part of what we do as GPs. There's obviously really good ways that we can prevent skin cancer. So I always like to, we'll talk about this later, but in skin cancer check, in a skin cancer check, I really like to talk at the end about the different ways to reduce your risk of skin cancer. So the slip, slop, slap was what I grew up with in the late 80s, early 90s, and seek and slide got added onto that. So I like to show people, the Skin Cancer Council of South Australia have a really good handout that you can show people and really talk through those prevention strategies, so that you can say to people, look, I love cutting out skin cancers, but if you do this stuff, we'll reduce the chance of that happening. So keep yourself safe and you'll keep away from me. It's a really good way of busting some myths is talking about UV radiation and where that fits in the electromagnetic wavelength. So obviously the light we can see is right in the middle there. Infrared is invisible, but it is the heat that we feel from the sun. And UV radiation obviously is a higher frequency. It is not, you can't feel it. So, people that say, oh, I got windburn, no, you got UV burn over the course of a few hours on a day that was overcast and possibly didn't feel hot. So it's really important to teach people that UV radiation is accumulative across the day, especially for people that are pale like me. You might only need to be in the sun for an hour, even in the winter, on a day that's sunny but doesn't feel hot, and I will get some sunburn, or UV burn, you might call it, because the sun sort of implies that the sun's out. Wind might make your skin feel dry, but it doesn't burn your skin. So just always debunk that wind burn myth when you can and say it's UV radiation, it's sunburn. Obviously, the higher you go in Australia, sort of the latitudes are saying decrease, I guess you'd say. There's a higher index of UV as the sun sits high in the sky. So this is just set from autumn what the average UV is in the middle of the day. So you can see down where we are in the lower parts of South Australia. So the average of the UV radiation sits between 5 and 6, and as you get up further north, past me and Clare, up to Port Augusta and beyond, you're getting up into that 7, 8, 9 zone. So that's obviously in autumn at noon. This is where it can get to over the year. So the UV index obviously shoots up higher as the sun the Earth's axis tilts around to summer, and we cop more of that sunlight in the summer months. And the average UV through that Christmas time of the year, New Year time, is quite high. So these are times we're really asking people to be quite wary in the middle of the day, and also in those danger zones around autumn and spring, where people might be a bit more blasé about not covering up, and I'm certainly guilty of that too. So really just explaining to people how UV radiation works. It's not dependent on heat. It doesn't matter if it's a cloudy day, it still gets through the clouds and can burn skin. There's a great app through ARPANSA, which is the radiation service of Australia. They actually take readings in all the major cities of UV radiation. They can give a forecast of what it's planned to be today, which is more easily readable on a weather app, but you can actually look back at the day and see what the actual recorded UV radiation is, and you can go back in history. So that's quite an interesting thing to look at. So when we're talking about skin cancer, there's obviously a lot of risk factors that play into that. So these are some of the risk factors that, if they're present in your patient that's sitting in front of you, can increase their risk of skin cancer. So the relative risk of all of these is different. I know that previous history of melanoma is one of the highest risk factors for future melanoma, but so too having fair skin, having really severe sunburn when growing up as a young kiddo. So if someone gets a number of sunburn episodes across the back of their neck, say when they're young, they have a much higher risk of melanoma in that area as they get older. Obviously, people who are outside more have a higher exposure to UV radiation. So it's a good idea to ask what they do for a living. Are they a farmer? Are they out on the road working? Do they have incidental exposure like teachers do, or even police officers when they're on the roadside? If there's a family history of melanoma, can be some genetic markers that predispose to that. And even if they have had non-melanoma skin cancer, that can predispose them to being more predisposed to having melanoma itself. The other one that's not on there, well, the other two, sorry, that I do ask in my skin check consults is about smoking. Obviously reduces the immune system's ability to clear skin cancer, and also immunosuppressive medication. So people that are on methotrexate, monoclonal antibodies, or even anti-rejection medications for transplants, high risk of skin cancers in those populations. So with skin checks in general, there's not a huge amount of evidence. It's really hard to tease out whether skin checks actually make a difference. But I believe that for people that have those high risk factors that we talked about just before, that they do benefit from having a skin check. And we'll talk about how frequently that should be for people, or how frequently I suggest people have a check. Having a consent process is really important, not just about that you're going to be stripping down to underwear and lying on bed and having us look over you, but also just that a skin check isn't infallible, that there are often spots that are very small for us to see, but if we've had training, then the ability to pick up skin cancer is much higher. So just have a good consent process. It might be a written one. It might be that you've just said verbally, look, we're going to look over you today in your underwear. You can have a sheet over if you want. We'll do our best to pick up any skin cancers, but we can't guarantee we find all of them. Just a way to just explain to patients that it's not sort of a 100% success rate. It's pretty close though. And then have a technique. Look, it doesn't matter which way you check people as long as you do it the same way every time. The reason for that being is that you don't miss stuff. It's why we get taught particular processes in our examination of patients, even in medical school. It's just so you have a system, you don't miss things, you don't overlook certain areas. So my system, for what it's worth, and feel free to use this or do your own thing if you've already established that, is I have people lying on their back. I check from their feet, between their toes, up their anterior surface of their body, around their groin, and I ask them, do you have any spots on your genital region that you're aware of? And, do you mind if I have a look if there are any that you're worried about? Across the abdomen, same on the breasts for women. Are there any spots that you see in the mirror in the morning that you're worried about? Are you happy for me to have a look? Just as long as you're signposting things along the way. Looking then across the front of the face, each side of the neck and behind the ears especially. And then you ask them to roll over onto their front and say, I'm now going to check your back. And soles of the feet are easier to check when they're lying on their front, you'll find. Always make sure you check under their underwear on their buttocks area. There's always a couple of moles there that are hiding away. Up the back, through the back of the neck. Sometimes you might have to get patients to tuck their neck forward to see the back of their neck, because when they're lying on a bed, the neck is often scrunched up, and also checking through their scalp. And I often ask, are there any spots that your hairdresser has noticed? Sometimes the hairdresser might have picked up a couple of spots and said to the patient, just make sure your doctor checks that spot on the left part of your scalp. We've had 3 melanomas in Clare that hairdressers have actually said, that looks a bit suspicious, get it checked out. And when we've looked at it, we've said, yeah, that's probably melanoma. And sure enough, the biopsy has come back positive for melanoma. The history is important. So if a patient says, I'm worried about this spot on your arm, on their arm, really important to have a look at that and either give them some reassurance that you think it looks fine if it is, or if it's a spot that looks a bit suspect, then I would have a low threshold to do a biopsy. It's important patients know their skin the best, and if they're worried about a particular spot they haven't seen before, that could be nasty. And it's not a great look if you dismiss them and say, oh, that's fine. And, down the track, it comes back that it was a skin cancer, because they'll remember, I told that doctor that was nasty and they said, don't worry about it. So just you have to be really confident to know it's not nasty before you move on. And be opportunistic about your skin checks. You don't have to be doing them in a dedicated skin check clinic. You might just see one on someone's neck like this lady. I did a ultrasound guided steroid injection a couple of years ago, and just before we moved the gown down to do the injection, we looked up and saw this little spot and said, oh, how long have you had that little lesion for? Oh, I haven't really noticed that one before. And a new spot like that, it came back as a little SCC that we got rid of. So same when you're auscultating a chest, have a listen to the patient's lungs without their shirt, so you can have a look at their back. There's lots of melanomas to be found on people's backs that they might not have known about. So let's look at the diagnosis of skin cancer. We'll first look at the tools that we use to diagnose it, and then we might look at the different types of lesions. And feel free to ask any questions in the chat there. I'm happy to answer them as we go along. I've got the little chat box open. So the dermatoscope is a standard of care for pigmented lesions. If you don't have a dermatoscope and you're looking at people's skin, trying to find skin cancers, especially if you're holding yourself out as a skin cancer doctor and doing checks, you need a dermatoscope. It's written up in the melanoma guidelines from the Cancer Council as a standard of care. It's gold standard. You have to have one. You'll likely miss melanomas or other lesions if you don't use it. So if you do have a dermatoscope, then you think about how to actually pick what's skin cancer and what's not. So there are lots of different algorithms that you can use. We'll talk about a couple of them tonight to work out what to biopsy, because that's essentially what you're trying to find out. Which one am I happy to leave? Which lesion do I need to cut out to see what it is? Subkeratoses are hard. They're really ugly lesions, and you can often cut them out thinking it's a melanoma. So don't be despairing if you're finding a few of those. They can trick you. They've tricked me before, and we'll look at some examples of that. And just do lots of checks. You know, if you've got your dermatoscope, use it. If you're, doing auscultating someone's back and you see a few lesions, once you've had a listen with the stethoscope, grab the dermatoscope and have a little look at some of the lesions on people's backs. You might be surprised with what you sort of see, and just get to know what looks normal and what looks a bit suspicious, and you'll build your own internal algorithm about what's nasty and what's not. I always am in a habit of taking a picture of the lesions that I do send off for histology, mostly so that when the histology result comes back, I can look back at that lesion and see why it was a melanoma or why it wasn't. And that helps tune my brain for what I'm looking for. The question then is, this is an image-based diagnosis. Is this AI proof? The answer is absolutely not. And we'll talk about the exciting opportunity that AI and machine learning neural networks brings to this kind of medicine. So there's lots of different types of dermatoscopes. These are a couple of them there. Heine have a whole range. The other mob are Dermlight, and there's also Aluco. There are probably some other brands, but they're the three that I know about. Some people have just a little miniature one that connects to their phone that they can use a bit more easily. And some have a bigger dedicated dermatoscope that's sort of a bit more weighty and easier to move around the body. So look, my advice would be is to try them when you're at a conference, a doctor conference. Pop over to some of the tables and have a look and have a test of the dermatoscope, see what they look like, and have a chat with a skin cancer doctor that's already got one. They should be able to give you some advice about what are good ones, what are not great ones, and what they suggest. So dermatoscopy, like I said, it's a standard of care. Again, just want to drum that in. If you're going to do skin checks, you need a dermatoscope. They have both polarized and non-polarized functions, and polarized light is much better for seeing deeper structures, whereas non-polarized light is good to see some other types of structures, but only use that maybe 5 to 10% of the time. Most of the time using polarized light. It means that you don't have to use oil or immersion fluid with the dermatoscope. And we talked a bit about before that the diagnosis of skin lesions is very much dependent on different algorithms, but they're all fairly equal. So we'll talk about the algorithms. It doesn't matter which one you choose, as long as you choose one you're comfortable with it. This looks like a bit of a double up. So keratosis will trick you, just to put that in again. But we talk about AI soon. Really important that you make sure you're in a comfortable position. It's really easy to get a sore neck and a back after a day of doing some skin checks. So make sure you position the patient and the bed at an appropriate height. If you are getting right up close to the dermatoscope, like you can see in that picture there, you might even consider connecting it to your phone and being able to look at the lesion from afar. There are also handheld magnifying sort of loops, I guess, that are on the market. You can look at those to scan the body first and then zoom in on a particular lesion with the dermatoscope when you need to. Like I said, AI is the future. So there are already some companies one being PhotoFinder, another one called Derm Engine, and I think also Heine are looking at using image analysis to help diagnose skin cancer. I guess the way I think of it is, I've done skin cancer medicine for the past 10 plus years, and what I remember in my own head and having seen pictures and the diagnosis come through afterwards is my own internal algorithm. How many lesions that is? Gosh, it might only be, I don't know, 1,000, a couple of thousand lesions that I can remember in my head and what they look like, and building up my own gestalt. Imagine a computer that can call on millions of images and have absolutely accurate memory and not sort of be a bit faded in time. So it's still in progress, but this sort of technology will absolutely outstrip, even the best dermatoscopists. So yes, like I said, we'll talk about the features of different skin cancers, but don't get too hung up on them. It's really good to know the basics, because the future is coming. There are also other devices. I've been involved with some research involving this device called the dermasensor from the US, and it uses light to bounce off deeper structures in the skin to see which lesions are cancerous and which aren't. The idea being that cancerous lesions bounce light off differently than non-cancerous lesions. These are all decision aids, aren't they? They are going to help us make a decision about what we are doing, rather than being the final diagnosis. This is one of the algorithms called Chaos and Clues. It is one of the algorithms that some doctors use to decide whether to biopsy a lesion or not. So if you're interested, you can Google Chaos and Clues, and basically, if there's asymmetry or chaos in the lesion, then you go down to the next step and look for a particular clue of malignancy. If you satisfy both of those criteria, then it's worthwhile biopsying the lesion. And Anthony's just mentioned those big magnified loops are good to screen, then use dermatoscope. That's great. I haven't quite built it into my system yet. I kind of feel like I need a holster to hold one and then the other to have two hands. So I'll have to have a bit of a play with that, maybe a scrub top to put my dermatoscope in while I'm using the loop. But thanks for that feedback, Anthony. The other algorithm that I know of is called the 3-point checklist. If a lesion has asymmetry, an atypical network of its reticular lines, as we'll see later, and blue-white structures, then it's if you get any one of those criteria, then it's worthwhile biopsying. And if you have a look down underneath that, you'll see there's a little graph, which is a area under curve. It showed that I think it's about 6 or so of these different algorithms all fit in within a certain p-value. They're all equivalent to each other. So it doesn't matter which one you use, as long as you're comfortable with it. That's a good algorithm to decide what to biopsy and what not to. So when we're talking about blue, white, black, brown colors, what does that actually mean? What it means is, especially when we're talking about the black, brown, grey to blue colors, that is what level the melanin is in the skin. So if you are seeing black colors, that is melanin that is very close to the surface of the skin. As it gets through the dark brown, going lower, light brown lower, grey even lower, and blue is melanin right at a deeper surface. So if you're seeing grey and blue, that's suggestive that the melanin is very deep down, and it's likely to be something like a melanoma. Orange and yellow are keratin. We often see them in seborrheic keratoses. You'll see pictures of that today. The white can be collagen and scarring. So, if you're seeing white, that's another bad sign. And red and purple, obviously, blood. And if we're seeing red and purple, often they are suggestive of hemangioma, cherry angiomas. They're quite typical to see. So you can see some of the examples there, especially over on the far right, that that lesion, even on the bottom right, has that grey, it's got blue, it's got probably some white lines. It's an ugly lesion. It's clearly one you're not going to leave. That's likely an invasive melanoma. So you can just get an appreciation of trying to work out where the different layers of the melanin are based on the color of them. That's from an RACGP article, that color chart, so you can look that up pretty easily. So they're all different types of lesions. I guess similar to when I was working first as a rural doctor, one of my colleagues said, the first thing you've got to work out about a patient is, do they need to come into hospital or not? Do they need to be admitted? Then it's a pretty easy discussion, like they're in or they can go home. It's kind of a similar thing with skin cancers. You're deciding, is this lesion malignant or is it benign? Do I need to do a biopsy? Or can I leave it alone and say to the patient that's fine? Obviously, there are many different types of skin lesions. We'll talk about a few of them today and some of the dermatoscopic look of them. So here's just a bit of some data from our clinic in Clare. This was over a 3-year period, looking at the different results that we got back from lesions after biopsying them. You can see that melanoma are quite low down there. That you don't actually find many melanomas, which is a good thing because they're nasty. Dysplastic nevi, which are a great melanoma masquerades, close by at 10%. We'll see some pictures of those. SCCs and BCCs do make up the bulk of malignant lesions or cancerous lesions, typically around the sun-exposed areas. And then there's lots of benign lesions too. So, people will talk about, what's your number needed to treat for melanoma. I sort of don't worry too much about that. If you are cutting out lesions that you are suspicious that are melanoma, even if a lot of them come back that they're not, that's okay. Patients are often quite appreciative that you're being thorough and making sure. So it's always interesting just to reflect back on your practice and see what numbers of lesions you're chopping out. So let's dive into pigmented lesions. We all know what melanomas are. They are aggressive, metastatic potential lesions. They often look quite ugly, which is helpful, easier to find. And the deeper they are, the worse the survival rates are. However, nowadays with immunotherapy, survival rates are quite good. We've had quite a few nasty melanomas here in the mid-north, and patients have had amazing outcomes on immunotherapy and have really good survival rates. So the aim still is, though, try and catch it early before it takes off. And let's look at some pictures. So you can see they don't look evenly coloured. They look ugly. They're not a nice colour. They can also be that pink and brown you can see in the upper right there. So if you ever see a lesion that's a bit pink and brown, it just doesn't look quite right. Certainly do a biopsy. Everyone would certainly be doing a biopsy of that one on the left side, though. It just looks ugly. That's got some nodular component to it too, which suggests that it's already got some invasive component. Some more pictures there again, just showing that the barn door melanomas are ugly. So lots of dermatoscopic features. You can see those previous pictures a couple of slides before. There's the blue-white veil. There can be big globs around the outside, which suggests radial growth. It means that the lesion is growing. Lots of a thickened network, and we'll have a look at some pictures of that reticular network, and that's often the basis of picking up melanoma. When that reticular network looks weird, that's when it's worthwhile chopping one out. A lot of the pictures and information are from DermNet NZ, which is a great free resource from New Zealand. It's just got lots of photos and just helps you get your head around what you're looking for. So here's some pictures of malignant melanoma under the dermatoscope. You can see, say in that top left-hand picture, you can see some of the network, and it's just been obliterated in certain areas. It's been eaten away. Same in the one on the top right is where the arrow is. You can see some of the network there, but the rest of it just doesn't look the same as that. So yeah, look, they look as ugly under the dermatoscope as they do in real life. Same with these ones here. Grey-white veil, you can see. And in that bottom right-hand side, that network has been chomped away. So you can see the body's trying to get rid of that for a certain reason, obviously because it's a malignant cancer. Sebkeratosis, like we talked about, can trick you. They are those stuck-on barnacle type lesions. A couple of my patients in the country call them senile warts. Just be careful who you say that to. You might get a few weird looks if you say to a nice old lady she's got some senile warts. So sebkeratosis, we don't have to biopsy these unless you can't be confident that it's not melanoma. Like we'll find there are some that are a bit tricky looking, or they're catching on clothes. They might catch on a necklace or a bra strap or pant line. You can certainly get rid of them then for patients if they're just saying, this is really annoying, can you please get rid of it for me? They're very common on those sun-exposed areas, and they tend to hang out in groups. So you can see there, this person has quite a few SEB-Ks. Now, the trick becomes then trying to find the melanoma in amongst all of that. So people that have these sorts of spots might have high sun exposure. They might be growing some melanomas as well. Some more pictures there of that classic warty look. They can be very flat too. You'll get good at picking which ones are SEB-Ks as you look at them. So they've got those yellow-orange clods, as we mentioned before. They might have curved reticular lines. They might have like a cerebriform pattern. They might look like a brain, a very, very sharp border, vessels sort of round in loops all over the place, and there will be lots of them together. So that's a bit of a giveaway too. If you have lots of lesions that look like that, they're likely to be seborrheic keratosis. Here is what they look like again under the dermatoscope a bit more. You can see those milia-like cysts, the keratin plugs. You can see that they just look a bit amorphous. They don't have a reticular network. They don't have that lattice pattern that the melanomas, and we will see simple nevi have. Here's someone's back, and you can see it's really hard. That person's had a lot of sun damage. Maybe there is a melanoma or two in there. And there certainly was on this guy who I saw probably 5 years ago now. He'd been a fisherman up north of Queensland, and he had a couple of melanomas on his back. So I wondered if people wanted to have a type in the chat box there which letters they thought were melanoma. Feel free to have a little type away in there, and I'll just wait for a couple of people to type in A and D or E and B, C, B, whatever they think. And I'll let you know which ones were melanoma in the end. Don't be shy. No one wants to type anything in? All right. So C&E, thanks, Justin. C&E, yep, they're good choices. Anyone else? Yep. BC, thanks, James. Welcome. Kangaroo Island or Antarctica, wherever you're calling from. B, C, and E. Yep, Willem, C and E. Yeah, that's good. Absolutely. They were, I'll go through them. So A was a seborrheic keratosis. And look, I'll just say, and Cecilia, A, B, C, and E. Yep. I'll be clear at the start. I know exactly what each of these lesions are because I biopsied them all. Clearly they're not all melanoma, but I only can tell with confidence what these were is because I cut them out. A was a seborrheic keratosis. It's got, I thought had some network at the top, but they're more those little milia cysts in the middle. So that's a SEB-K. B, yeah, James, you picked it, and Cecilia. It is a SEB-K colliding with a melanoma. So you can see down the side there's some SEB-K looking structures and still some SEB-K in the middle. And then that top section is all invasive melanoma. So it was a bit of a collision lesion. C, absolutely, Willem, and I think Justin, James, you picked C was a super melanoma in situ. D was a SEB-K, and E, yes, again, was a invasive melanoma. So you can just see how tricky it can be with someone with that level of sun-damaged skin. And certainly you might spend half an hour really doing a proper skin check looking at this person, not just 15 or 20 minutes. So, Monica, is that something you've got your hand up for there? Maybe not. So good one. Yeah,
All good
excellent. That's
from
just
my
a,
end.
yeah, far away. Oh, you, no, all good. So dysplastic nevus. So you might get some patients that come in and say, oh, I had a few lesions and the doctor said they got rid of it, but it was kind of lucky because it was about to turn into a melanoma. The current consensus is that, or look, what I like to tell people is um, these are lesions that are weird looking. We don't know if they turn into melanoma or not because we can't biopsy it, get the diagnosis, and plug it back into their skin and see what it will do. So what I like to say to people is if you have had a dysplastic nevus or multiple or a high dysplastic nevus with high grade changes, your risk of melanoma is higher than the regular population. So it's kind of like another one of those risk factors. So I don't say to people, lucky we got this early because it could have turned nasty. We don't know that, but what we do know is these are people you'd probably keep a closer eye on because their skin can create these moles that look a bit odd. So it's really hard to work out whether they are melanoma or not. They can look really ugly as well. And I should mention, if it's a dysplastic nevus with high grade changes, then the consensus is you should treat it as a melanoma in situ with 5 mm margins if you get that biopsy, because there's some conjecture about what histopathologists will call melanoma and what they won't. My general rule is if a histopathologist says, oh, it doesn't quite meet the criteria for melanoma, but is this, if they've mentioned the word melanoma in the pathology report, treat it as if it is a melanoma. It's probably a lot safer for the patient. And we're only talking about 5 mm either side of your original biopsy at 10 mm defect diameters, not massive really. So here are some pictures of dysplastic nevi, again from my friends at DermNed in New Zealand. You can see they look quite odd, and you might think, oh gosh, I've got to biopsy all of these. And you might biopsy the nastiest looking of them and just see what you get back. These are some people that I do recommend have total body photography. I have a nurse that I work with she's only in her early 40s. She's had about 3 melanomas and 10 highly dysplastic nevi. She gets a yearly skin check with a total body photography. And I think for her, that's actually really good medicine. When people who've had no skin cancer get asked to have a total body photography every year, that's likely overservicing for mine. So just trying to find that balance. Here's what they can look like under the dermatoscope. Like you can see, these are ones that just look odd. The one up on the top right has the radial growth. You can see those clods around the outside, means it's growing outwards. The one at the top left looks chaotic, certainly would chop that out. You could argue the one on the bottom left has some changes in its reticular network, and there's some pink and brown in that bottom right. So these are all ones that I would be very happy to biopsy. And a good point there Anthony makes in the Q&A, you could ask for a second opinion, ask them to have another look at some other levels of the biopsy. They might do some other stains, or if it's a junior pathologist, they might send it up the chain to someone more senior. Yeah, that's a really good point, Anthony. Solar lentigo. These are what people might come in, say they've got a bunch of liver spots. They're just a very boring, bland, usually beigey type macule on especially sun exposure areas. You see a lot of these on people's faces, forearms, dorsal of the hand, heaps there, and also on their legs. So if you see these, they often look pretty typical. Patients will say, look, they've been there for quite a while and they haven't changed very much, which gives you some reassurance. But again, if you're worried about any of them, you might do a little biopsy. You'll see that sort of fingerprinting rather than the classic network structure that we saw in the dysplastic nevi. Benign nevi, they can happen anywhere on the body. They could be just a flat mole. They can be raised. They can be all sorts of colors, but they tend to look pretty regular. So that's the giveaway, really, that they don't look chaotic or ugly. And there are a whole different type of different nevi or moles. Let's have a look at some of those now. So there can be compound, junctional, intradermal nevi we see lots of. Blue nevi pop up occasionally. Combined nevus. So they look fairly typical. And they often will have a hair coming out of them. And patients will often say that they've had that one for many years. Dermatoscopic features, they often will be one particular type of structure within them. So rather than having a mishmash of different structures, they'll all look pretty typical together. So if we have a look at some of these, you can see the cobblestone type there. It'll be cobblestone through the whole lesion. It won't be just one side and not the other. That one on the left there looks a bit like Australia with Tasmania at the bottom. They might have a reticular network, as you can see. And they just look very even. Bit sort of indescript there on the left, and just those globules on the right. But again, that's probably one that I would biopsy on the right side. If someone said they hadn't noticed that before, you can see those globules around the outside would suggest that that lesion is growing. So certainly wouldn't be upset if that one got biopsied. Non-pigmented lesions. So these are the classic ones we see a lot on our sun-exposed patients, actinic keratosis or solar keratosis. These clearly happen on sun-exposed areas where there's been years of UV radiation, and they can turn into SCC over time. I think it's 1 in 1,000 chance of those, but it does happen. So I tell people, look, this is not a skin cancer. It's a sign of sun damage, and we just need to watch these areas because that's where you've had lots of sun. You can freeze them off if patients are bothered by them. We'll talk about this at the treatment section of the talk. Can chop them out if they're looking a bit more proud or hyperkeratotic, or there's different creams we can use as well, which we'll talk about. And they're those scaly, nodular, raised. They can often be a bit itchy or painful in the sun for patients. So you've seen these before, the backs of farmers' hands, tops of scalps without hair in people that are quite pale. And then, more pictures there of that classic scaly, irritated skin. Can be often quite hyperkeratotic. They might get quite raised keratosis on them, which can be quite debilitating. Won't spend too much on the dermatoscopic features because we pretty much pick them up based on the clinical view of them. So I would really just focus on looking at those lesions from afar. When you look at them up close, there's not really much to see apart from slightly more prominent blood vessels, background sun damage of the skin, and some keratosis. So what are those risk factors for people that might have solar keratosis or actinic keratosis turning into SCC? It's hard to know across a population, but we think it's just sun exposure, past history of other skin cancers, if they're immunosuppressed, like I mentioned before, and those big lesions are the ones that tend to kick on. So they kick onto this SCC. They can spread like melanoma. They can be invasive, especially around the scalp and the face, but they're usually not as aggressive in other places like melanoma is. So we like to treat these fairly aggressively as well. These tend to be in sun-exposed areas. Keratoacanthoma, a slightly different beast, can grow very quickly, but don't tend to then just keep growing and getting nasty. They tend to involute. The trick being that you can't distinguish them clinically. So the only reason you find out it's a keratoacanthoma is when you cut it out. So very much a classic sort of volcano type lesion, central keratosis, and ulceration. You will have all seen these sorts of ones on people's faces and arms and those sorts of areas, sometimes on the leg as well. Quite typical looking. So there's some other ones there. So again, I do still put my dermatoscope on these lesions, but we often pick them up clinically first without having to look at them. So you might see that sort of surrounding structure around the ulceration. But again, it's a history of change, not healing up, and it looks nasty, likely to be SCC with that central keratin. SCC in situ, Bowen's disease, or intraepithelial carcinoma, choose your name. I just tend to call them IEC. It's easy to type into the notes. Again, sun-exposed areas, very common lower legs. You get these big macules down there, and unfortunately, patients often get them misdiagnosed as sort of a patch of eczema or tinea, but the trick then is that it's not responding to those usual therapies for them. They can turn into invasive SCC over time, but that's rare as well if you're onto it early. And we'll talk about the treatment. You can either cut them out or freeze/use cream to treat them. And here's what they look like. I think there's a couple of lower limbs, pretty classic spot for it. Those sort of macules there. Dermatoscopic features. They have that scaly surface, sometimes pigmented structures, but again, really it's that clinical diagnosis. I often pick these without looking at it through the dermatoscope. It's got the positive purple sign there. Why do the nodules sometimes fall off? Is that when we were talking about that? Was that with the SCCs there, Anthony? I'll come back to that when you let me know. BCC, again, these are pretty classic, aren't they? They tend to be in those sun-exposed areas around the face, anywhere where people aren't really covering up. And you can usually say to people, look, if you have to choose a skin cancer, this is the type to have. With SCCs, the nodules, I guess it's that keratin will come out. People can either flick off the top level of keratin, or sometimes that nodular skin, but those squamous cells are still there and will keep growing. BCCs, I often say that this is the type to have. It's a skin cancer, but it's not necessarily going to spread around your body. I think it can happen, but it's super rare. So I just say these are not known to spread. And they grow very slowly, so we've got time to chop these out. But there are different subtypes, and where they get a bit tricky is certainly the infiltrative subtype. And the reason they're tricky is because they tend to turn up in places like a nose or an ear, and it's hard to see where the edge of the lesion is. So if you have a nodular BCC, you can see very clearly, and we'll see some pictures of where the edge of the lesion is. Draw your margin, chop it out, and be sure you've cleared it. The infiltrative lesions are very, very tricky to see the edge. So if I ever do a biopsy and find that there's an infiltrative BCC on somewhere like a nose, and I'm not confident with the definitive excision, I'll often send them to a plastic surgeon or even someone who's access to Mohs micrographic surgery, so they can actually check that they've got the right margin before they close. Superficial BCCs are much more of a patch, a bit like the IECs, but the classic nodular BCC that you see the most of are a fleshy, raised, pearly-edged nodule and have arborizing blood vessels. So there's a patch of superficial SCC on the left there, and then a classic nodular BCC on the right. There's some nodular BCCs again. But just beware, if you do a biopsy of a lesion that comes back as a infiltrative BCC, you really want to make sure you have a clear margin, or if you're not comfortable and a bit worried, send them on. So yeah, again, I tend to only like to look at BCCs under the dermatoscope because they're quite pretty things. The arborizing blood vessels are pretty classic. You get this sort of grayish background colouring, and the pigmented BCCs have blue and dark clods in them, which are quite pretty as well. But you can usually pick these before you even put the dermatoscope on them. So you can see there the BCCs have that classic arborizing blood vessel. You can see in most of those pictures there. And that one at the top left is a pigmented BCC. Get those blue-black pigment globs. Right. Sebaceous hyperplasia. This is the one that usually tricks young players. It's a nodular, non-nasty lesion, especially across the forehead. It's a benign hair follicle tumor, and they can be quite common on people. And I guess that's the trick, is that there's lots of them on someone's face. They're not likely to have 10 BCCs sitting across their forehead. But if they've just got one, they can lull medical students and junior doctors into biopsying these. So they look fairly typical from afar, and you can see another patient with them across their forehead. And they look quite typical under the dermatoscope as well. They almost look like they've got sort of popcorn in them. So if you like this yellowy sort of popcorn look to them, very, very classic sebaceous hyperplasia. They may have some blood vessels that look a bit arborizing, but they have that classic yellowy color rather than a gray, slaty color and that true arborizing blood vessel. But again, if it's something that's a singular lesion there, solitary nodule that you're not sure about, patient says it's come up quickly, do a biopsy. If you consent them and say, you know, this is to be sure, certainly do that biopsy. Then there's some weird and wonderful. So I don't think I've ever diagnosed a Meckel cell carcinoma, but they're around. You know, if there's a quick growing nodular lesion and your biopsy comes back as that, very aggressive, worthwhile getting rid of, you know, sending that one on to a specialist. They might need quite a bit of specialist input. Sebaceous carcinoma, I've seen a couple of these on patients, especially on their nose. They can be common in the eyelid there, as you see, but I've seen them quite a bit on, I've seen about 3 on patients' noses. The reason these are important is that they are associated with Lynch syndrome, so high risk of bowel cancer in families that have sebaceous carcinoma and Lynch syndrome. And yeah, that was a bit of advice from one of the visiting ophthalmologists, that if a patient has a chalazion that it's just not quite getting treated and you've had some antibiotics or it's been last and nothing really comes out, that actually could be a sebaceous carcinoma. So have a low threshold to send people like that on for opinion. And I've seen one of these in my time, an atypical fibroxanthoma, or AFX they call them. It's sort of a weird growing lesion, usually on the one I saw was on an ear, from what I told, surround the face. They're usually quite benign, but they grow fairly quickly and they look nasty. So yeah, often they get biopsied and cut out as a rule anyway. They can come back too, not that they spread necessarily, but they can be hard to clear. Right, that's the halfway mark. We're not going too badly, about 2 minutes to 8. So feel free, please, to stretch your legs, do some calf raises, get rid of that DVT risk. I'm going to have some antioxidant wine to reduce that risk. And then we'll crack on to the second half, which is about skin cancer treatment and what we can do for some of these lesions that we've just seen. So I'll just give you half a minute there just to stretch your legs. I'll just check that I've not missed any calls from the hospital. Right, we should crack on. And if we finish 5 minutes early, then we can have an early minute. So skin cancer treatment. The first question I guess we have to ask is, well, I should edit this slide. Do we have to do anything at all? Is this a lesion we can leave and just watch? Or is it something that needs something done about it? If you decide that there's something that needs to be done about it, there's obviously 2 main pathways we can go. one that's going to involve chopping their skin, and one that involves not chopping their skin. So how do we choose that? I guess there's many different parts that come into that decision. And for those of you guys who I can see on the list there have been doctors for a while and skin cancer doctors, this will just be natural to you. You'll just know the pathway from experience. But when you're first approaching it, I guess you think about first the location of the lesion. Where is it? Is this going to be a difficult closure for me? Am I going to have to do a flap or a graft? And if I can't do those things, I might have to send them away. Or can I get away with some non-surgical treatment if it's a type of lesion that is okay for that? If there's a lot of lesions all grouped together, that might take out surgery as an option. You might think of more of a field treatment. And then balancing some of the side effects and complications. So anytime we're cutting into people's skin, there's a risk of bleeding and infection, the two main risks. And different patients have different risk factors with those. They might be on blood thinners, or they might have a quite poorly controlled diabetes, or be smokers and not heal well. So there might be a reason not to look at surgery for those people, or the fact that it might be on a lower limb, right down near an ankle, quite hard to heal. And then about the cosmesis. So there's scarring involved with any time we do surgery. You look pretty horrible when you're taking a course of field therapy, Epidix, which we'll talk about. And also, if we're doing cryotherapy, there's a risk of depigmentation of the skin. So a lot of different factors come into that. And I guess hopefully when we're talking about some of the different options, you'll sort of see which ones you might use in different times. So the non-surgical options we did mention there, that basically there are options for just watching and waiting. If it's a lesion that a patient's pretty confident's been there for a while, and you are happy enough just to watch it, you might just see how that goes, take a photo of it, put in your clinical notes, and then look at it later compared to what it was. There are some dedicated software that allow that, but it's pretty easy just to take a photo, pop it in the patient's file, and then re-look at it again compared in a few months' time. Cryotherapy, we should all have access to. Quite a good treatment for solar keratosis, some forms of IEC, and even superficial BCC. We'll talk about Epidix and Aldara, the two main topical therapies. There's a newer one called Actikerol, which is a lower dose Epidix, which combined with salicylic acid for quite hyperkeratotic, quite tough raised skin. Can be really good at getting right down into that. Picardo's off the list. Just like to mention that in case anyone's still sort of wondering what happened to Picardo. It came out sort of in the middle of my, it had a lot of time in the media as I was going through the middle of my skin cancer training, because it actually had been found in European studies to increase the risk of skin cancer. So clearly not a good skin cancer treatment if it's causing skin cancer. Then there's some more specialist-based therapies like PDT, surface fit radiotherapy, otherwise called VMAT, which we'll talk about, and immunotherapy then for people that have melanoma that's already up and running. Again, that's through your friendly oncologist. So field treatments, when would you use something that's like a cream to use over a big area of skin? Certainly a big question you have to ask for people is, do you have anything you're going to be at for in photos or weddings, or just any event where you're going to be around other people that you would like to look your best, because those of you who have used Epidix or seen people with it makes you look like you have the plague. So really important to clarify with people, are you in anything for the next month or two, because you're going to look pretty terrible, and let's choose a time when you are not going to be around those events. Give them clear instructions. There's information sheets made up by the company, sometimes actually worthwhile making up your own, just with the important information. What can you do if you get a bacterial superinfection? Always just say to people, if you're worried at all and you're not sure, come back and see me. It's always worthwhile catching up with them during their treatment course just to see how they're going. Really good trick is to use steroid cream at the end of their course of Efudix or Aldara to help clear up that inflammation. People often the inflammation takes a while to heal on its own, so using the topical steroid can be quite useful. And try not to use it in the warmer months because it can burn the skin even more. So this time of the year, in late autumn, now winter, and then into early spring, really good time to use these topical treatments. And then what's nice about it is if you might see on someone's scalp, they're covered in solus radiation damage, you use a field treatment, you get rid of all the background noise, and you might see, oh, there's a little BCC sitting there that I couldn't see before because it was lost in the mix. So really nice way to reduce that background noise and see what you're left with afterwards. So here's an example of an old lass who's used Efudix or Aldara on her face. That's probably quite mild, even on that left side. It can go a lot more red than that, and then goes quite keratotic and scaly, and falls away to be quite nice. So when they finish the treatment, you might give them a little tube of some betamethasone just to pop there and to actually clear up the inflammation after it's done its job. So here's the different types there, and I've just listed what they're covered for under the PBS. So Efudix isn't listed on the PBS, so it's an out-of-pocket cost for patients. You'd have to check with your local chemist. I think ours was here in Clare somewhere between 60 and 80 bucks for a tube of Efudix, which would do a good lot of treatment for one sitting. Aldara it can be covered by the PBS once you've got the diagnosis of solar keratosis or superficial BCC. And you can also use it on IEC as well. Actikerol, as I mentioned, are for those really quite raised warty lesions. I haven't used it yet, but I know that it's out there. Picardo's off the mix. It's off use now. And yeah, try and look at getting patients to use it for 3 to 4 weeks or as long as they can, and then use a steroid to clear it up. And yeah, they'll be quite thankful for the way their skin looks afterwards. It comes back quite nicely. They just have to get through the hard yards of it. As I mentioned, surface radiotherapy. I've only sent one patient down to Adelaide for this. They had quite a bit of sun damage on their legs, and we would otherwise just be freezing or burning off their whole skin. So they actually had a course of this on their leg, and it looked quite good in the end. Can last for quite a while. I think it's Genesis Care, the only mob that still do it. It's essentially just focuses the radiotherapy to the surface of the skin, doesn't sort of cook the internal organs like they do for other cancers. So it can be quite useful. Immunotherapy, yes, this is where I send to my friendly oncologist. Lots of monoclonal antibodies. They've all got weird names. So there's lots of different types. You can certainly look up the Cancer Council guidelines for melanoma. They have lots of information about the different immunotherapy types if you're interested. Some of them have fairly intolerable side effects. So, but again, this will be more for the oncologist to talk through patients about that. Just to know that, people do get diagnosed with invasive melanoma. It's not the end of the world. There's actually really good systemic therapies now that have quite good survival rates. So you can help your patient work through that and say, look, there's some really good treatment out there available. And just for interest's sake, there was a study done quite a few years ago now in the New England Journal of Medicine about using vitamin B3 for non-melanoma skin cancer prevention. So these are for people that are at a higher risk of BCC and SCC. They actually showed that I think it was BD dosing of nicotinamide reduced their overall incidence of those types of skin cancers. So interesting one. Hasn't sort of worked its way into regular use yet, but yeah, certainly the evidence is quite compelling. So when is it time to cut? Biopsy or excision. For those who know their pop culture, this is Weird Al Yankovic in his song Like a Surgeon. So biopsy or excision. this is my sort of general take on things. If a diagnosis is really clear, if you see a spot on a forearm that looks just like a BCC, and it's quite easy to get margins around it, you can just cut it straight out. You don't have to do a biopsy first. If you think that's what it is, chop it out, and clear the excision. If you're not too sure, like you think, oh, maybe this is an amelanotic melanoma, or it just doesn't look like a BCC, or it might be on somewhere that's a bit tricky to do a big excision, like on, say, it's on a nose or an ear, even the foot can be quite hard. Then you might want to do a biopsy first to know exactly what you're dealing with, especially if you're dealing with a infiltrative BCC on a nose. If you get a biopsy that shows that, that's certainly one that I tend to handball rather than trying to take on myself. If you did a big excision and it came back as that and you hadn't quite cleared it, then you're saying to the patient, sorry, we did a big excision here and it's still not cleared. I'm going to have to send you to someone else. If you've done a little punch biopsy and you've got the diagnosis and they haven't had a huge cut, then they'll be pretty thankful that you've picked it up but haven't done anything too drastic. And certainly with melanoma, if there's one thing to take away is don't just chop the whole thing out, planning for it to be a melanoma. Don't chop it out with 10mm margins on either side. Just get a thin biopsy first, so 2mm either side, so that you can find out what type of melanoma it is first. Because if it's invasive melanoma, yes, you will need 10 to 20mm on either side. But if it's a melanoma in situ, you only need 5mm either side, which is quite a different excision. And if it's a dysplastic nevus with low-grade changes, you don't actually need to do any more. You've already treated that lesion. So when patients say, oh, doc, if you think it's a melanoma, just chuck the whole thing out. You just explain to them, look, we just need to do this step by step so that we're not doing too much if we don't need to, and to make sure we're treating it correctly. Because if there's some really suspicious changes or aggressive features to that melanoma that you've done a biopsy on, you mightn't even do the next excision. You might send them straight to an oncologist or the melanoma unit at the RA. So that's an example of a little lesion on a nose. I think this one was an infiltrative BCC, and we just did a little biopsy first, and it came back as that. And I that would have needed probably 5, 6, 7mm margins either side of the lesion. And that's quite a large cut. That's a big flap. Even for someone like myself who's done a lot of flap surgery, I just got to know when to fold them, know when to run. And that was one that she was thankful we just did a little biopsy first without having to go a big cut and then doing more. This is a cautionary tale from when I did an outreach clinic quite remotely. This fella had this spot on the side of his temple there, looked suspicious for melanoma, but I didn't have a shave tool, or I don't think I had enough time. I think it might have been with the RFDS. We were heading away, and losing light and needing to get out of Marie or wherever we were. And he said, oh, doc, I just really want the biopsy. So I think I ended up saying, well, look, I've got a punch biopsy. We'll just do a quick punch in that little central area there that looked the nastiest. And he said, that's great, fine. But here's the thing, we only sampled that little section there. We didn't sample the other parts of the lesion. So what ended up happening is it said, yes, it was melanoma, and it said melanoma in situ. That's fine. We knew we needed to get 5mm either side of that lesion. So we did a what's called an AT flap to bring the lesion together. But when the histology came back for that full excision, they said, actually, there's an area of invasive melanoma just to the side. It might have been perhaps sort of just above where my punch was. So we actually had to come back and get another 5mm either side as an ellipse just in that section. So that's just a little trick there. If you're ever going to, don't ever partially biopsy a melanoma, and just even be confident with the patient to say, look, I can't do that today. Your best treatment is going to be a full biopsy of the whole lesion to send it away. And that might need to wait a month or two. That's just what it is. Or you could, if you are worried about it, you could ask him to travel down to, in that case, it would have been Port Augusta. So yeah, cautionary tale, he ended up with the right treatment, but it just was a couple more steps than it should have been. So ellipses, I mean, I've sort of dived into a bit there, just seeing a flat, but 90% of the time you can get away with doing an ellipse, just a straight side-to-side cut. The tricks with those is draw the ellipse, 3 or 4 times longer than the diameter of the defect. So make sure it's nice and long so that you don't have too much tension. When you're stitching it together, make sure the needle's going in at 90 degrees to the skin, and we'll talk about this at the practical sessions if you're coming to those around the state. And exit out the other side the same, coming out the skin at 90 degrees. That makes you get a nice big deep bite of skin, and you're going to evert the edges a bit. Find your relaxed lines of skin tension, relaxed skin tension lines. They might be different if patients are sitting down, lying, standing. So we often will say to someone, hey, lie down on this bed and I'll chop this out lying down. But if they're sitting up, the skin actually comes together a bit of a different way. So you might actually draw the ellipse on them while they're sitting up, and then lie them down and then cut it out that way. I usually draw lines going across the lesion as well, perpendicularly across. You'll see some of the orthopedic surgeons when they make their line to chop out a knee or a hip when they're replacing it, and they put a whole bunch of tram track lines going perpendicular across the wound so they know how to line them up afterwards. I tend to put 1 or 2 across my ellipse just so I know, yep, I'm going to make sure I line those 2 lines up to make the ellipse quite even. Undermining is great. Try and use blunt sections. So you just use your scissors underneath the skin, opening them up rather than using the scalpel blade, which could risk damaging structures that you can't see. Deep dermal stitches are your friend. So get to use Vicryl or monocryl, and get to do some deep buried sutures. They're really useful. I had one today in clinic where the defect was about 25 or 30 millimeters and looked massive. I thought, oh my gosh, I don't know if this is going to come together. But I put 4 or 5 deep dermal sutures starting at one end and going down to the other, and it was pretty much all back together even before I'd put the superficial sutures in. So if I had tried to put just superficial stitches in, I would have really struggled to bring it together and pull it together. But those deep dermals were just fantastic. So if you haven't got those, just ask your clinic to see if they can get them. They are expensive, but they're very much worthwhile. And if look, you're struggling to close the wound right in the middle, start at one end and just zip it up like a zip. It might not come together as straight and evenly, but you'll certainly close it. The other technique is to use a little pulley stitch. And again, if you're coming to the practical, I can show you a pulley stitch, or hopefully there's a doctor in your clinic that might show you those too. The other trick too, if you've got very dry or thin skin, especially on some of our older patients, you can use the steri strips across the wound and actually suture through those. They can provide a little bit more bite and tension to provide that grip. I've used that. I haven't used it myself, but one of my colleagues was having trouble with sutures pulling through, and I had never used it. So I said, hey, should we try this? Patient, we're just going to do this because we're having trouble. And worked a treat, just provide that bit of scaffold for the suture to hold. So that's quite a good trick if you need to use it. So always look at the relaxed skin tension lines, the RSTLs. So if you Google that, I think DermNet, yes, it's from DermNet, has the picture of where those lines tend to fall. But you'll find them because you can relax the person and then pinch their skin and see which way it's easier to pinch them. Don't use Langer's lines. Langer's lines were developed from cadavers, so I don't know how many of you are cutting out skin cancers from cadavers, but the skin obviously does different things when someone's dead. So, and especially on the face, because from what I'm taught, the Langer's lines are actually perpendicular in some places on the face to the relaxed skin tension line. So certainly the skin cancer will come, the defect will come together, but you might have a nastier scar than if you otherwise follow the RSTLs. So just always look at that, but just in doubt, pinch the face, have a look where it's coming together and see what's going to work. Right. Highway to the danger zone time. So where are those danger zones around the body when we're cutting things out that we need to be aware of? The main ones that will come across around the face, we've got a few structures that are quite close to the surface and that run superficial to structures. So the main one, especially up around the temple area, is that top blue section. It's the temporal branch of the facial nerve. So anytime you're up in that area, the facial nerve with the temporal branch runs superficial to the zygoma. So anytime you're around that area on the cheek and up through the temple, just be really, really mindful that you don't not going too deep there. You can leave patients with a permanent ptosis, which is not a good look. They'll have a constant droopy eyelid. The accessory nerve sits down the bottom there in the posterior triangle. It runs fairly superficial as well. Usually for skin cancers, you're pretty safe, but if you ever get asked to remove a cyst or something down in that area, I'd have a low threshold to send that away. I've seen one patient that has had an accessory nerve injury from a doctor cutting out a cyst in that area and went to the medical defence company and was quite a large payout because they were quite a physical person and were unable to use their shoulder and arm very much after that. The branch of the facial nerve and artery down near the angle of the mouth, that can be quite a lot of bleeding there, but also if the facial nerve in that area is injured, the patients can have a unopposed contraction of the muscle and they can have a permanent scowl look, and that's not a good look either. I should also mention the temporal artery. So not only the facial nerve, the temporal artery up in that temple area can bleed quite a bit as well. So it's quite an easy one to palpate. And I often will mark it out next to where I'm chopping out a skin cancer, so I know to stay away from that area. Perineal nerve down on the just below the knee there on the lateral side of the leg runs quite superficial around the head of the fibula. So just being wary too, if you're deep in that area, there's a risk of foot drop for patients, so that's not ideal either. Flaps and grafts. So why would we do them? For anyone that knows, the top areas on the wing there of the aircraft, they're called spoilers. It's the bottom part are flaps. They increase the surface area of the wing, leading to planes being able to fly slower for the same amount of lifts while they're landing, like birds do. Interesting. So you use a flap or a graft when you can't close the defect with a simple ellipse or secondary intention. Sometimes you can cut out a lesion. If it doesn't come together enough, there might be a little central area and you dress that and it will heal up quite nicely. It just doesn't look as nice initially, but can come together quite well. So every time you're looking to cut something out and you're thinking about doing a flap, still think, can I do an ellipse here? Like maybe I just have to do a really big one, but can I still do an ellipse? And that's an example here. This fella had this big superficial, I think it was a nodular BCC and superficial BCC on his neck. Quite a large lesion. It might have been sort of in the order of, 25 mil again. And you sort of be tempted, oh, should I do a graft here or a flap? It's quite large, but he had quite a bit of loose skin there and that came together quite nicely just as a simple ellipse. He was a bugger though. He's a local fella and I told him we had to consent about the accessory nerve, given that we're in that area, but even though we're superficial. And when I saw him next down the street, he said, oh yeah, Jerry, I can't lift my shoulder. I was like, oh, what? And he said, nah, just gotcha. Didn't happen at all. So you got to be careful about who you're telling all the information to, because they, if they're cheeky, they might throw it back at you. So what are we doing with the skin graft? Flap, sorry. We're using skin from an area next door that has a bit of excess skin and can move it into place to cover the defect. And it's often it's a better cosmetic match than a graft because we're pulling the skin from right next door. It's not bringing a graft from behind the ear to the front of the nose. We're pulling the skin that's right next door. It'll often look a lot better. And we can often follow what are called cosmetic units and keep those structures intact, which helps the cosmetic outcome. The nice thing about it is we can do it under local anaesthetic. Sometimes there might be a little ear block you might use or a facial block, but you don't have to put people under sedation or a general anaesthetic for these usually, unless someone's got a huge aversion to surgery and needles. But most patients you can do in your rooms with these. And the other nice thing, especially about grafts, is they can preserve anatomic function. So where an ellipse might interrupt the function of part of the body, where it be the eye or a joint, a flap can actually allow the function to continue. And there's a lot of challenge about it, and it's fun. You can be artistic. There's not one size fits all for things. It's a medical challenge because a lot of medication choices come into it. It's surgically challenging. You want a cosmetic outcome. I find it quite interesting and fun. But again, you don't have to do it all the time. Most of the time, my day-to-day surgery is doing ellipses. I might do one flap every 2 weeks or so, or once a week if I'm busy with skin cancer stuff. And for the amount of skin cancer stuff I'm doing, it's not very often. So we saw this fella. So there are heaps of different types of flaps, and a lot of them are a version of each other. So I don't expect you to know all this off by heart, but just to know there are heaps of different types of flaps, and they tend to be useful in different areas. So you've got sort of a bit of a kit bag of flaps to use in certain areas. We'll talk about just some of those basic ones. If you're coming to the practical class, we'll do some of these basic ones on the night. So the most basic is a transposition flap. There's lots of different types, but this is one I did on a fella who was getting 10 millimeters around a melanoma excision. You can see where the original biopsy was, and they're now 10 millimeter margin. And essentially, it means we're just doing a smaller cut. So for that spot on this bicep, the ellipse would have been most of the length of his arm, whereas this meant we just had a little cut and a few stitches down in that particular area. The idea, obviously, is to try and keep the base oriented proximally. So this is the top of his head where the arrow is coming from. You want the flap to fill up with blood from that proximal end. It's a proximally based flap. Just like when you see those flap wounds that people create for themselves on a leg, and it's a distally based flap, and you think, oh God, this is going to fail because the blood has to get right around and back in. Make it easy for yourself. Make sure that the flap is coming from that top end down. So you look out for the normal complications of any excision. That's it: bleeding, infection, dehiscence, but especially the other one to be aware of is flap necrosis. So the tip of that flap is the part that is at risk, and that can be made worse by a narrow neck of the flap. So if that base you can see where the arrow is pointing into isn't wide enough, or if there's bleeding underneath the flap, if you haven't got good hemostasis underneath the flap, pressure can build up. You can get a hematoma, and that can squeeze the blood and not allow that to perfuse the flap, and it can die. But again, it can serve as a bit of a scab on top, and then the wound can heal from the bottom up, so not all is lost. So here's a version of a transposition flap on an ear. You can see it'd be really hard to do an ellipse in that area going up into the hair and down, and where do you pull the ear forward? So there's some lax skin underneath that lesion for that BCC, and you can pull that when you cut out that BCC, undermine that whole area and rotate it up into place. And you can see we've pulled that up into place there. There's the base of the flap anterior, and so the blood comes in from that area, and you can see it heals up quite well. There was a bit of what we call pin cushioning happening there, the skin sitting up a bit higher than the level of the ear, but prior to having a big BCC there, he was pretty happy with that. He was a builder, so he didn't care too much how he looked. Rotational flap is another type of flap. You can just see cutting out a little wedge of skin and then pulling the skin around into place. The trick with these ones is to have quite a long cut. So the more rotation you get, the less tension there is, 4:1. So if the length of your pizza wedge there is, say, 1 centimeter, then your flap length should be 4 centimeters, that circumference. Sometimes you might cut a little dog ear at the end because it pulls the skin up, which you'll see in the next slide. And you really need to make sure the blood is not flowing underneath this, because if that flap gets blood underneath it, it can die. Of course, there's always blood vessels and nerves poking up from below, so just make sure you're not cutting too deeply. And if you've got an assistant who can hold a skin hook and pull the skin around and use a diathermy to help stop any bleeding, that's useful. I routinely will mark all of the lesions that I take out, especially with these ones, because it's really hard to know. Let's say if we go back to that previous one where, if I chop this skin cancer out and one of the edges has a positive margin, I didn't quite get an edge of it. Where is that now? Like, where am I cutting out where that skin cancer might be on the edge? So use a marking suture so that you know if there is a positive margin, you can orientate yourself and know where you're going to be chopping out making sure you're chopping out the residual skin cancer. And that's even true for ellipses. It might be easy just to think, well, I just need to do either side of the ellipse, but it's nice to know which side is more involved than the other, so you're taking a bit more on that side. So this is a big rotation flap from when I started doing these. Advancement flap, I think we were talking, rotation flap. So nowadays I would do more of a curved, I would probably angle it a bit higher above the cheekbone there and bring it around the side. But this one still closed very well. This is for a melanoma. And we'd had a biopsy originally, a shave biopsy. And you can see that back cut across the side of the face was needed just to help balance up the dog ear. But again, if I had have probably drawn that as a nicer, rounder shape and a bit longer, I may not have needed to do that. So I think in this case, my aim was to try and preserve that nasolabial fold that you can see. So I wanted to try and keep the wound based around that. So, but that healed up quite well as well. This AET flap is my workhorse. I use these the most, I guess, because I see a lot of skin cancers just above the eyelid and below the eyelid and to the side. So that's where this one gets used quite well. It's kind of like you're pulling the skin from either side, like curtains to close the hole. Really good for anywhere you don't want to be pulling up from below. And that's especially around the eye and the lip. You don't want to distort the shape of someone's face. And it also not pulling up means if you say, well, why don't I just do it up and down? If you did it up and down, it might sort of get close to the eyebrow of the eye. And so my little example of Mr. Bean here is if you did do a horizontal ellipse, you would be pulling the eye up, or the lip. Or if you wanted to orientate it vertically, it's then sort of going down too low into the eye. So it creates a best of both worlds. You combine the two in pulling the skin side to side, as you can see here. So for quite a large defect, you're not pulling the skin up and changing the shape of their eyebrow or their eye. You're pulling the skin from either side. It comes together quite well if you undermine enough. And you can see I've chopped some little dog ears out of there, or Burroughs triangles, so that it doesn't the skin doesn't tent up, because you're clearly cutting out a big part of skin in the middle and not doing anything from the bottom. So there's going to be some bunching of the skin there. V to Y flap, I don't need to do many of these. It doesn't come up very often that I can't use an ellipse in this area, but this is a little flap where instead of rotating the skin around or cutting underneath it, you're sort of cutting around the flap and pushing it up like a little conveyor belt, little island pushing up into the defect. It's really good on the side of noses where you've got some skin on the cheek to push up onto the nose. And it's really good, especially for that nose, because it preserves that nasolabial fold, that line between the alar of the nose to the edge of the lip. Lots of undermining is useful. Using deep stitches is useful, and having an assistant to use a skin hook and hold it up into place is good too. So this is an example of a guy a couple of years ago for me that we did a V to Y flap on. And you can see he had a nodular VCC on his nose, and we just moved that flap of skin from where it was, pushed it up, and managed to maintain that nasolabial fold around the edge of the nasal alar down to his mouth. Another example is called the running man flap. And so this is reading man. You can sort of imagine that this is the round is the head. The person's holding up a book to read, and their body, stick body going down. And the reason this is a useful one is because it pulls skin from that preauricular area where there's usually a fair bit of loose skin, and you push that flap into the hole, and then that bottom little triangle can go backwards. It's all a bit hard to picture in your head if you can't see it being done, but the idea is basically it just moves the tension from, rather than pulling the side of the eye, it's pulling the skin from the back area and using it up from there. And you can sort of get a sense of that from near this in the pre-photo. You can see he's got a few little flaps of skin there in front of the ear, and they're sort of straightened out a bit after the flap. So what's next? And this is a little O to Z flap. You can see that this lady had a nodular keratotic lesion on her foot, and very hard to get enough skin to close as an ellipse there. So we've used skin from either side of the foot to pull together and bring it together in that way. So it's using loose skin on the side of the foot and the top side of the foot to meet in the middle. You can imagine, pull them together. You had to cut underneath the skin to be able to pull it together like that. And the final one, I haven't shown any full thickness skin grafts, which I only use very rarely, but this is one that's a bit of a novel idea, which is called a halo graft. It's especially for lower limbs, where there's not much skin on the anterior shin. There might be a keratotic lesion there that needs to be removed. And instead of cutting the lesion out and putting in a split skin graft or a full thickness skin graft from somewhere else onto that defect, you use a shave biopsy blade and cut out little pebbles of skin and then plug them back into the hole there to heal up. So it's sort of like a split skin graft next to itself. Clearly not a technique to use for a malignant or not well demarcated lesion. So if you have a melanoma or something that looks suspect, you certainly wouldn't be using this, because you're essentially putting the surrounding skin back into the defect there. So this is for well demarcated lesions. You make sure you have a good margin and that the chips of skin are far enough away from that original defect. But can take a little while to heal, like all split skin grafts do. But there's the benefit for some elderly patients is it's just one wound site. There's not two different areas there that they have to manage. So I guess we've put the cart before the horse a little bit in talking about how we chop out things, but how much do you need to chop out for each lesion? So melanoma have very prescriptive guidelines about this, backed up by high-level evidence. So these are from the Cancer Council guidelines. If you Google Melanoma Cancer Council Wiki, you'll get to the guidelines. It's a living document online, and it's very clear about those margins. So when you get the biopsy back, if it's melanoma in situ, 5 millimeters is fine. Lentigo maligna, which tend to be around the face and neck, they do suggest to be a bit more aggressive in your excision margins. So they suggest up to 10 millimeters. So I tend to go by that and treat with 10 millimeter margins if you're able to. If I can't do that and I'm worried about it, then I'll send them off. Invasive melanoma obviously then depends on the Breslow thickness that you get back as part of your biopsy report, your histology report. So if it's a Breslow thickness of less than 1 millimeter, I should have said there, sorry, those Breslow thicknesses are in millimeters, then your excision margins are as per there. So there's a bit of wiggle room between 1 and 4 millimeter Breslows, 1 to 2 centimeters. look, if I've got anyone who has a Breslow thickness of 4 and it's a invasive melanoma, there's probably some ulceration and there's a high risk that has had some metastasis. So I don't think I've seen a Breslow thickness above, might be 2. So anything above that, I'll be sending away. Basal cell carcinoma, 3 millimeters is fine. They're not an aggressive skin cancer, but high risk lesions, which we'll talk about what they are, you can go up to 5 millimeters. SCC, a bit more, but can go up to 6 millimeters if they're in high risk areas. There's not great evidence for others, so just have a chat with your histopathologist and local friendly skin cancer person to work out, if you get something like a atypical fibroxanthoma, what should you be doing with that? There's no clear guidelines about those. So these are the different features that suggest BCC and SCC can be a normal risk or then high risk. So we talked about those infiltrative BCCs being high risk. You certainly want to take a bigger margin for those or refer on. And if it's a recurrent BCC of any type, you treat that as high risk because there's clearly it's got some way of getting around things. SCC, if it's poorly differentiated, if it's around the head and the neck, especially in, they say, the H zone of the face, so around the forehead, eyes, nose, and any of those, they call them cleavage lines, where there's areas where the SCC can dive down. So if you've got anything that just doesn't look as normal or you're worried about and it's high risk and you don't feel comfortable, just please refer it on to a specialist, or even there's a local doctor who feels comfortable with those lesions, run it past them as well. Then this is sort of the tricky one that's a bit woolly, is how often do you actually follow up people that after they've had a skin cancer? So there's some guidelines around melanoma about how often it should be, and it's more frequent follow-up based on the level of the stage of melanoma that it is. So if it's just a superficial melanoma, then annually is appropriate. And they say for 10 years. But, some people might not have a melanoma after 5 or 6 years and they say, well, I'm sick of doing this and you haven't found anything. You could probably stretch it out a little bit to every 2 years. There's no evidence for non-melanoma skin cancer, what we now call keratinocyte cancers. But it's, there is a higher risk of those people having skin cancers rather than other people in the population. So it is worthwhile them having a regular follow-up. I tend to base it off patient factors themselves. So after a skin check or a cut out of skin cancer, I'll work out how often they need a skin check based on a few different factors, based on their history. Those risk factors we mentioned right at the start, so family history, sun damage growing up, how old they are. If they're in their 20s, they have a lower risk of skin cancer than someone who's in their 70s who's worked outside as a farmer for years and years. So I often recommend, say someone has a melanoma, has had a melanoma, they work outside, I'll just say, look, have a skin check every year. It's not too hard, just come in and we'll check you over. If there's someone that's had a BCC or 2 and they're in their 50s and they're at low risk, they usually work inside, I might say come through every 2 to 3 years. If they've had, no skin cancers, but they work outside and they're a bit worried, you might say you have a skin check every 4 years. So you base it on their level of risk and also how often they're likely to come in. But patients can have a skin check whenever they want. If they're someone who's concerned and their mum died of melanoma when they were 50, absolutely. If you want to have a skin check every year, that's fine. I'm happy to be reassuring and look over you and still talk about prevention and just check up. I do get a few patients that are in the teenage years or even their early 20s, and they've got zero risk of skin cancer. These days and age, most kids are actually well covered up when they were younger. They might go off the rails a bit when they're teenagers, rebelling, but that risk of being outside for long periods of the day, cooking themselves, in in their teenage years, not as high as it was in the 60s and 70s. You can usually be a lot more relaxed about catching up with them, and you might say just have a skin check every 7 or 8 years. Using the CST reminders for young women is a good one. You can say, look, once you have a skin check every year, you have your CST reminder. So, every 5 years, if it's normal, is a good time frame. And set a recall through your practice software. You can say, look, I'll put a reminder on there and you'll get a text message or a letter in a couple of years' time, and we'll catch up then. But feel free to catch up anytime before then if you're worried. So then we get down to the nitty-gritty of Medicare. It's a good idea. You obviously will measure a lot of times to make sure you've got a good margin, cut once, but then document your margins. So, if you're cutting out a melanoma that's 10 millimeters, you can say, I did a 2 millimeter margin, or cutting out something you think's a melanoma, 8 millimeter lesion, 2 millimeters either side, total defect, 12 millimeter margin. So if you document that, then you're covering yourself. If Medicare do audit you and say, why did you build this number? You can say, well, I thought it was a melanoma. Here's the size of it. Don't always rely on the histology report for the size of the lesion. Like the lesions can shrink up to 20-30% in the formalin. So make sure you're measuring it at the time of the excision. And use photos if you need to. If it's a complex excision and you think Medicare might be a bit uppity about it, make sure you take a photo, and then you can put that in the patient file. And if you do get audited, you can point them to that. I haven't been audited since I was I think a 3rd or 4th week registrar, first time in the country in Woodner, and I got a call from Medicare saying, this is the compliance section. Did you bill item 23 on this date? Yes. Oh, yep, just checking. Good. I think they put the wind up all the new registrars, and then don't check you again unless you're doing stuff that's right off the script. So, but just be careful about it. Like Medicare numbers, rebates for patients for excisions are quite well remunerated. So if you're doing stuff that's off piste, Medicare will look you up. Flat item numbers, they used to be quite liberal with what they allowed those numbers to be billed, but now they're based on the size of the lesion and the location of the lesion. So you can only bill a flat item number if it's a lesion bigger than XYZ on the ear, or if it's this size on a hand. So it doesn't mean you can't charge the patient that, but it just means you can't bill those numbers together for certain ones, which I'll show you on the next slide. There's a new group of item numbers for suspected melanoma. The reason being, if you chopped out a seborrheic keratosis thinking it was melanoma and it came back as seborrheic keratosis, you were only entitled previously to bill the what's called a biopsy number 30071, which is about $40 or something. That's not quite fair when you thought, oh, I actually thought this was melanoma, and so there are now suspected melanoma item numbers that you can bill instead of that. And I guess this is me saying, like, this is what you bill Medicare and the only money you get for cutting out skin cancers, but essentially Medicare is that patient's rebate, and I'm sort of talking about whether you're accepting the Medicare fee as the payment for the lesion, or whether there has been a gap fee. But another way to think about it is, and a few practices do this, is charge what you think you're worth. So say if you spend half an hour with the patient for a particular procedure, like you would for a consult, you charge this, costs you this much money, and you can pay that fee. And depending on what the lesion is, Medicare will pay you back some component of that. If it was a melanoma, you might get it all back. If it wasn't melanoma or something else, you might get this much back. So that's the other way to look at it. Don't always just assume that Medicare's paying you all this money and that's all you get. If you want to flip it around the other way, you charge what you're worth, and then Medicare pays the patient back depending on the histology. This is the item number guide that I mentioned. So this is very useful for your practice or yourself if you're working out what number are you entitled to bill for yourself or for the patient for what you cut out. So it's classified into different regions. Area 1 is the tricky spots like the nose, eyelid, eyebrow, lip, finger, whatnot. And then you split up into the four main types of tumor, cyst, ulcer, or scar. So pretty much everything not skin cancer, or SEBK, I must say. Seborrheic keratosis is always billed as a biopsy number unless you thought it was melanoma. BCC, SCC, another group of lesions, melanoma, another group of lesions, and then suspected melanoma. So that's the numbers for those tricky regions, and they're obviously above and below 6 millimeters in diameter. And you can see there for the above 6 millimeter lesions is where you can bill a flat I number. So let's say you take off a BCC that is 3 millimeters, it's a 3 millimeter margin on a nose. Medicare will say you cannot bill a flat number with that. You should be able to close that just as an ellipse or a little punch biopsy. We're not going to pay you a flat number for that. But if your defect is greater than 6 millimeters, they say, well, that's fair. We understand you might actually have to use a flat to close that. Don't have to, but you can. The next area is the face, neck, scalp, nipple areola, distal upper limb, which distal upper limb means the wrist down, and the distal lower limb means the knee and down. So there's just that difference between the upper and lower limb. So it's not like elbow down, it's just the wrist down and then knee and down for the lower limb. And then area 3 is everywhere else not covered by that, which is most of the trunk, thigh, forearm, arm, those sorts of places. And you can see that the sizes differ there too. So Medicare chips in more money if the lesions are much, much bigger on those other areas. Cool. So that one you can get from Sonic Healthcare. I think there's other mobs that come up with these, but that's quite a handy reckoner to use. And then these are some of the resources. So these are sort of the 3 books that I got initially and started with. They're all really good. The Practical Skin Cancer Surgery is just a good general book covering all the different components of skin cancer, setting up the tray, what tools you need, how to look at follow-up care, all that. The Local Flap book's a great one when you start advancing out into doing some flaps, and it, like I said, gives you a bit of a toolbox about what to use and where. And it's just a start, like those examples that that fella uses, Pennington, are just one option. I did a skin cancer masterclass in Melbourne a couple of weeks ago through the College of Skin Cancer Surgery, and it was fantastic. For every different lesion that we looked at, there are about 4 or 5 different options of different ways to close things. So that's another nice part of it all. And the Dermoscopy Atlas, yeah, really good one just for looking at different types of lesions. But again, like I said, AI is coming, so it'll be good to know the basics, but I wouldn't get bogged down in trying to be an absolute expert in knowing every single dermatoscopic feature about every lesion, because we'll have decision aids that help us a lot. You do need to know the basics, but that background knowledge will be much better from a massive algorithm and database of images. Obviously, there's online resources. So DermNet's something I look at quite a bit, especially in general practice, just for different rashes and things, showing patients pictures of eczema, palmopholic's eczema, and different things. When you find it, DermNet has great photos of it that people say, oh yeah, mine looks just like that. And I can sneakily have a quick look at the treatment and just make sure I'm on the right track with the potency of steroid that we need to use. Skin Cancer College, they're a great resource. I'm a member of them, and they have a couple of different options. They have a blog that has different closures and skin cancer cases. They have a talk board called Skin Talk, which talks about all different things from the Medicare billing through to what options for biopsy you can use. And like I mentioned, the Cancer Council wiki guidelines for melanoma are great. I think they are up to date now with the keratinocyte cancer ones as well. But the melanoma ones I go back to occasionally just to refresh my memory about what margin do I need to use here and what are some of the concerning features about different melanomas. So always nice to have that on hand. There are a couple of courses that you can do. I've done one of the health cert ones years ago that was quite useful when I started doing flaps. Like I mentioned, I just did the Skin Cancer College masterclass, which went over different flap types, which was great as a next level one up. If you're really interested in, then you can do the Masters of Medicine, which I completed a couple of years ago now. I think I did mine over 4 years or so, part-time. Just did a couple of topics per semester. And then, yeah, just find someone who's local who does a bit of this stuff and sit in with them, do some flaps. Hopefully there might be a morning you can line up where there's a couple of interesting cases. I certainly did that with a couple of registrars in the last year or two that come up to Claire and sit with me. There's a couple of plastic surgeons that are very happy to have you come and learn some things on a day where hopefully they're not doing, you know, massive breast reductions or anything. They might have a couple of skin cancers on faces that they've got in a list for you to help with and see how they do things. So hopefully, yeah, do that. There's my details there. Thank you very much for listening and staying awake. Hopefully not falling asleep too much. Thanks, Anthony, for the feedback. If you do want to get in touch with me, feel free to send me a message or give me a call or send me an email, especially if you're wanting to come up for half a day, do some procedures, and just to get some of those suturing skills. More than happy to do that. And you might see us at the practical course in, there's one in Port Pirie
Port
and
Lincoln.
one in Port Lincoln coming up
Yeah.
soon.
So Port Lincoln one is in August, 7th of August.
7th of August.
Yes. And Port
Lovely.
Pirie is in the following month. So
Port
we'll
Pirie
release the
in
flyers
September
soon.
sometime.
Yeah.
Yep. Stephen's just asked what dermoscopy course did I find useful for beginners? There's a few out there. I've had a couple of the nurses that work with me do the Skin Cancer College certificate of dermoscopy. It goes for about 3 to 4 weeks online. It costs about $3,000. But the nurses I have had do that have applied and been successful in getting the RDWA, what do they call it? Health workforce grant. That's can pay up to, gosh, I got to help cover some of my masters, so it was yeah, good couple of grand. So so the nurses that have done it through the Skin Cancer College have got the grant and it's pretty much paid for the course. So it's online. There's a little quiz at the end. So yeah, certainly would recommend that one. But just have a Google. There's probably some through Health Cert as well. Yeah. Thank you, Sonali. Appreciate that feedback. Are there any other questions or suggestions?
No. So
Doesn't
thank you,
look like it,
everyone.
but you've got my details there. So if anything scratches your head later on and you forgot to ask, please send me an email. Happy to answer it for you.